Drug Court Technical Assistance interactive webinar meeting with Dr. David Mee-Lee on what to expect from state-of-the-art addiction treatment for criminal justice populations in applying the new ASAM criteria. And we're going to follow up with questions that have come in yesterday and since after the session. I just want to again acknowledge that we had 46 states, people from 46 states participating, and in addition, Nova Scotia, Ontario, and Alberta, Canada, and I failed to mention, but also Brazil, Belgium, and Jamaica. So we have certainly international interest in this topic. I also wanted to mention that a number of you raised the issue about getting a certificate of attendance and a CEUs. We're looking into the CEU issue, but if anyone wants a certificate of attendance, if you would just send us a note that requesting that and indicate that you did attend, we will send you a certificate. We're going to also send out the recording and the PowerPoint slides shortly after this session, and they will be archived on our website, which I will send you. Just while you're with us right now, I just wanted to mention that the next session will be March 14th, and with a follow-up discussion, and I'll let Dr. Mee-Lee tell us about the topic for that one. And then on March 29th, we're going to have challenging cases. So we invite you to send us challenging cases that you've encountered in your programs, and we want to address them in that session. And then the following session, next session, will be on April 4th and 5th, and I'm going to let Dr. Mee-Lee talk about the topics for that. And again, we will send you follow-up notices. So with that, I want to turn this over to Dr. Mee-Lee, and we'll go through some of the questions that we received. But if you want to just talk about the next sessions, Dr. Mee-Lee, what you're going to be covering?
Yes, so on March 14, and then we'll follow up with the question and answer things after that. On March 14, we'll be talking on doing time or doing treatment and change, and really looking at how you can use phases in a function-oriented way, and to address the issue that many people who are mandated to treatment, it's too easy for treatment providers to just let them do time, and they go through the program and not actually do change. And we should be expecting people to do change and treatment, not to do time. So that's what we'll talk about on March 14. And then we invite people to send complex cases that we want to try to do on the March 29 session. And then on April 4, we'll be talking more about, actually, I just lost the title of it.
The stages of change.
We'll be doing stages of change, and I'm sorry, I just lost my notes here on what we called that one. But the one on April 4, you'll get notice about, and let me see. Well, anyway, I'll search for it while we're talking, and you'll get notice about it too.
Okay, so let's start with our first question, and this is from Tracy Dement. So if a judge wants to order treatment as a condition of probation or a sentence, he or she should just get assessed per ASAM and follow that treatment plan rather than order the person to inpatient or outpatient treatment for a particular duration. Is that correct?
Yes, so what we're recommending is that judges order assessment and treatment adherence rather than a particular level of care and a particular length of stay, which is really outside the scope of practice of a judge. That should be a clinical decision based on an assessment. But what the judge and the court team should expect is robust treatment with reports on whether the person is actually changing, and then also the reasons why they are in a certain level of care, and if they're changing levels of care, what is the clinical rationale for that. So the emphasis then on all important stakeholders, the client, the court team, and the treatment provider, is on, is this person really changing? rather than the emphasis being on, is this person complying with a certain level of care and length of stay?
Thank you. Okay, our next question is from Judge Mary Wagner. How do you know good assessments? How much access should the court have to them?
Well, I think if the goal of everybody involved with the participant is to improve public safety and decrease legal recidivism and crime, I think all important stakeholders need to be at the table of information. Now, of course, there are certain confidentiality things, and the client themselves, has a right for certain things to be confidential, but not in the sense of where people are not working together. So how do you know if it's a good assessment? Well, you know if it's a good assessment if, from the judge's point of view, if you can get feedback on it truly being an individualized treatment plan. If you get a treatment plan that everybody looks the same, and it's almost like you can't name that client by looking at the treatment plan, then there probably hasn't been a good assessment. Or there might have been good assessment, but people didn't use a good assessment in an individualized way. So the way a judge can tell if there's a good assessment is not by having some beautiful form filled out, but by getting a sense that, does this assessment translate into an individualized treatment plan that the client can articulate and that the treatment provider can explain to the court about what is going to be worked on to get this person to a functional state of improvement for the public safety. And how much should the court have access to that? Well, I think if the court says the client doesn't seem to know their treatment plan, and the treatment plan you gave me sounds like every treatment plan of every client I have in your program, I want to understand how you've done a good assessment and how you've used that assessment to really engage this person in a change process. So it isn't so much that the court needs to look at an assessment and say that looks like a good assessment. Any assessment can look very detailed and so forth. It's more what is actually happening to demonstrate and reassure me as a judge or a court team that something's going to happen to this person in a change process. And the only way I can tell that is if the client seems to know what they're working on to improve their function, and if the team, the treatment provider, can explain that to me. Now, having said that, in terms of the ASAM criteria, there is now a software product called Continuum, which is the ASAM-approved standardized assessment for the ASAM criteria, which has been invested in by the Substance Abuse and Mental Health Services Administration to the tune of nearly $1 million to connect it in with electronic health records. So there is a good standardized assessment for the ASAM criteria in that software. And you can read more about that at www.asamcontinuum.org. Continuum spelled CONTINUUM. So asamcontinuum.org. But having said that, just having a good assessment doesn't guarantee good treatment. And it's only as that assessment is used, as I say, in an individualized treatment plan focused on function and improvement, that the court team and the judge can know whether treatment is really happening.
Thank you. And we have another question, which is interrelated to Judge Wagner's question, but I think these concepts are so important that it helps to even repeat them. So this is from Dion Jones. If clients are not mandated to length of care, does this mean that programs are not to have a specific duration of time?
Yes. The answer to that is yes, because the time that a person should be in treatment should depend on if they're changing and if they're improving. Now, if a client is in treatment and they're just sitting there not participating in a meaningful way, and I don't just mean showing up and getting checked off on an attendance list, if a client is not doing well and they are not taking it seriously, they're not working on their treatment plan that's individualized, that's when I think the treatment provider has to go back to the court and say this person is out of compliance with the court order to do treatment that they agreed to do. Well, aren't they in your treatment program? Well, yes, but they're just sitting here. They don't even know what their treatment plan is. They don't participate. They're not making any changes that I can give you a report on in terms of their improving function for the public safety. I recommend some sort of sanction to get their attention. But the focus then is not on, when you put the focus on the length of time in a program, either from a treatment provider's point of view, we have a 30-day or a 60-day or 90-day program, and then when you reinforce that from the court side, you're mandated to 90 days or whatever, all the focus from the client's point of view is how much time do I have? That's why clients come into treatment, and the first thing they often say is, how long do I have to be here? If you have an answer in numbers, that puts the emphasis on doing time, not doing treatment and change. So the focus should be much more on what do you want, what are your assessed needs, and how are we going to get that? And then are you participating in an accountable, real way in treatment that we can see actual change happening? So I know this doesn't quite fit with a criminal justice mentality of set times, and it doesn't fit with many treatment providers who still think in fixed length of stay. But from the ASAM criteria point of view, from a chronic disease management point of view, there's not any fixed length of time for any other illness that we treat. There's no 28-day diabetes treatment programs or 30-day depression programs or 90-day schizophrenia programs or 100 days, asthma programs. It's what the severity is, what the treatment is, and what the outcome is.
Well, thank you. And I think this also is related from Lucy Letton. She said that the current debate between treatment and the courts is a very large topic in her jurisdiction. I have a question about how to help judges and drug court teams understand these concepts, because it's quite a change in paradigm. Do you have any suggestions on how we can better convey these concepts?
Yes, so I think we've done this a number of times in other courts and so forth. What I always recommend is that we need to get all of the stakeholders in the room, and by stakeholders I mean everybody who has a part to play in increasing public safety and decreasing legal recidivism. So that means the judge and the court team, that means the treatment provider, that means other important people on the team, probation officers, parole officers, defense attorneys, prosecuting attorneys. If we're talking about family court, child protective services, anybody who has an important stake in both the outcome and also is a position of power and influence. Everybody in that room is important because each of those stakeholders often have a different, not often, they do have a different culture and mission and a different set of concerns and priorities. All of those need to be honored and acknowledged and addressed so that we are not leaving anybody out, but at the same time remembering that all of those people are in the room to get the same outcome, which is a changed, functioning, sustained person who is actually going to change enough to increase public safety and decrease legal recidivism. So we have the same goal, but we often come from different cultures and missions and priorities. That means then we have to cross-train. We have to help judges know what they don't know and what's outside their scope of practice. We have to make sure treatment providers know what the priorities are of the court, that a treatment provider can't hold secrets from the court if the court is worried about a person threatening the public safety. There needs to be good communication between everybody so that judges and court teams can be reassured that public safety is not being jeopardized, but also that treatment providers can make sure judges are not going to work outside their scope of practice in all the levels of care and treatment, which should be under the purview of the treatment provider. So cross-training of judges and court teams to to providers about what we need and the kinds of things that are important to us, but vice versa, how can we work together and what do we ask of judges and court teams to not work outside their scope of practice, because that then ties our hands in terms of treatment. For example, if somebody gets a positive drug screen and a judge is going to sanction somebody for that, but in a treatment sense, a positive drug screen may be part of the treatment and part of a learning opportunity, we need to teach each other about how to get the outcome we want and how to work together so that we trust each other and are giving each other enough information to address the priorities of each stakeholder and their mission.
Well, thank you. Okay, we have another question again. Maybe I think it's related to this. Dr. Mee-Lee discussed the stages of change concept yesterday. What does he think about mandating defendants into a drug treatment court when the defendant denies having a substance abuse problem, despite behavioral indicators to the contrary?
Well, in the ASAM criteria, the 6 dimensions, one of them important dimensions, they're all important, but one that's clearly there is dimension 4, readiness to change. So from a treatment perspective, a person minimizing their drug use or not thinking they have even a drug problem or a mental health problem, or not thinking they have both, or thinking they don't have an anger problem, or thinking they don't have a parenting problem, all of that is normal in a clinical sense. Very few people rush into the emergency room saying, my life's unmanageable and I want serenity and sobriety one day at a time. I'll do whatever it takes. Most people who are in the legal system, the first thing they think is, it's not a problem. My problem is my probation officer or the police officer, or I'm being victimized. So having somebody not think they have a substance problem is normal for addiction. And that there means to be a treatment issue. That shouldn't be an admission criterion. If you only took people who were ready to embrace recovery, you wouldn't have any customers. What we have to decide is this a person who has offended and has broken the law? And if we think that person has done that because they have the disease of addiction, and if we think treating that disease of addiction would actually help us reach the goal of decreased legal recidivism and increased public safety, then we need to let treatment happen. Within the context of addiction, thinking you don't have a problem is normal and is probably the most common place a person starts who has an addiction. It's often the rarer case that you have people who's embracing that they have a problem and want to change their total life. So what I would say is that the main decision is, do we think addiction has a significant part to do with this person offending? And would we be better off reaching public safety goals and criminal justice goals by treating the addiction? That's really the decision to be made, not do they think they have a problem or not, because that's a treatment process that is normal for any good treatment program, to work with people who are at an early stage of change, who don't think they have an addiction problem, but think they have a judge problem.
Well, thank you. And that is such an important issue that we find in so many programs, where one of the criteria for admission to the drug court is the motivation of the individual. And so I'm getting the message, which we're trying to spread also, that that should not be a factor in terms of determining admission. That's something that the treatment provider works on. Is that correct?
Yes, and we're going to go more into this, I think, in the session on doing treatment and stages of change. That think of motivation as that if somebody agrees to be a participant in drug court or any other specialty court, they are motivated. It's what are they motivated for is how we have to start engaging them and then tie their criminal behavior to what they want. So even if what they want is just to get out of drug court, that's fine if they then are willing to participate in motivational work to help them connect that they have more of a drug problem than they think. So motivated is a term which we often mean, does this person really think they have a drug problem and willing to change their life? Well, that's what treatment's about. If they were so ready to change their life, they would have done this on their own.
Thank you. Okay, we have a question from Matthew Spencer. How often should a clinician be using an override for placement level of services? That is, if there's evidence that the client is minimizing use.
Well, again, this is related, that if a person is minimizing their use, that is just an awareness that that's often what happens with addiction clients. So when you say override a placement level, the ASAM criteria approach would be taking into account their readiness to change, and their stage of change is part of how you decide on the level of care. We don't have enough time to fully describe that and explain that, but it isn't a matter of saying you need to be in this level of care, and because you're minimizing, I'm going to override that. It's a matter of taking into account this person is going to need a lot of motivational work, and how can we best do that in what level of care? So I may be missing the question a bit, but assessing where somebody's stage of change is part of the overall assessment and placement decision.
And I think you had also mentioned the importance of continuing reassessing also.
Yes, absolutely, because it isn't like you put a person in a level of care and that's it. It's like any other illness. You need to start in a level of care. If you're improving, you may move to a less intense level. If you're not improving, it may be that you need a more intensive level of care, but it depends on your function and change, not based on a predetermined level of care and length of stay.
Okay. I have a question that's just come in from one of our colleagues in Brazil. What is the relationship between the ASAM criteria and the use of volunteers from support groups such as AA or NA to help inmates where there is no medical or nurse available to them? So in other words, how can volunteers work with people in accordance with the ASAM criteria?
Yes, peers and volunteers and AA are very important to integrate into the overall treatment plan. So the ASAM criteria, the sixth dimension is called recovery environment, and the fifth dimension is called relapse, continued use, continued problem potential. And in many areas of what treatment needs, peer supports, peer specialists, AA sponsors can be a great help. For example, in Dimension 6, to help that person develop a positive support recovery system. They can be a tremendous help if somebody on Dimension 5, the relapse dimension, is having cravings to use. You want them to call that AA sponsor and to make sure that they get some support from that. So that's where AA works very importantly with the clinical treatment. On Dimension 4, readiness to change, going to an AA meeting and saying, you don't have to go and say that you have a problem, but go there and see if you can just identify with anybody's story. And that can be a tremendous help in moving a person through stages of change. So throughout all of the clinical treatment, connecting people with peer specialists, peer support, AA, sponsors, and so forth, that's an integral part of the treatment plan.
Okay, we have another question from Eugenia Sosa. Regarding imminent danger that you mentioned, the definition, could you provide examples or further information on what would constitute imminent danger? And the second criteria is especially difficult to communicate to funding sources to keep clients in ASAM. And without compelling justification in this area, it's hard to get approval for more than 60 days of residential services.
So the ASAM criteria really talks about residential services, 24-hour care in the true sense of the word of 24-hour care, being for people who are in some imminent danger. Now, what that means is if you go through the 6 dimensions, and just to remind you of those. Let me find that on the PowerPoints here. Imminent danger for Dimension 1 would be somebody who is in very severe withdrawal and is likely to have a seizure or some life-threatening withdrawal. That would be somebody who would need a 24-hour treatment setting. And if they were very serious, that would need to be a medical setting. But you could have somebody who was in severe withdrawal, who wasn't necessarily going to die from a withdrawal seizure, but might need 24-hour containment as they come off cocaine or heroin or methamphetamine. So imminent danger in Dimension 1 is looking at severity of the withdrawal syndrome. Dimension 2, imminent danger would be, are they bleeding? Are they having trouble with severe chest pain? Are they vomiting blood? Are they having problems with very high blood pressure? They're going to have a stroke. It's that kind of imminent danger. Dimension 3 is looking at typical things of suicidality, homicidality, impulse control, violence. Is somebody going to be imminently in danger of harming others and harming themselves? And for the time that they are that way, they would need a 24-hour setting. Imminent danger for Dimension 4 would be somebody who says, I don't have a problem with drinking. Their speech is slurred. Give me my keys of the car. I can drive fine. In fact, I drive better when I'm a little intoxicated and I'm not so scared of the big trucks on the freeway. That would be somebody whose Dimension 4 at that point was imminent danger, because you don't want them driving drunk or stumbling in front of a truck and getting knocked over. So that would be imminent danger in terms of readiness to change. Somebody who doesn't think they have a problem and is going to act on continuing to drink or drive, even though it's very clear they have a problem. Imminent danger on Dimension 5 would be somebody who is having problems with cravings to use. They have such trouble in being able to moderate temptations to use that the only thing they can think of is to go out and to use something. And you see where people use against their better judgment, you would think, because they have such poor relapse prevention skills. And though what's imminent danger about it is when this person uses, they get psychotic or violent, or they think nothing of jumping in their car and driving drunk. That would be somebody who would need to be contained for the time that they're having that kind of impulse problems around continued use or continued mental health problems. There are many people who have trouble with cravings to use, but they may not be in imminent danger because they are struggling with relapse issues, but it's not in an imminently dangerous manner. Imminent danger on Dimension 6 recovery environment would be somebody who's going home to somebody who's abusive, who's going to beat them up. They're living with a drug dealer who's going to force them to use, or they're living with somebody who's going to force them to prostitute themselves to get money. So that they could be in imminent danger because it's freezing outside and there's snow and they're homeless. That would be another form of imminent danger. So all of those dimensions or combination of the dimensions can describe imminent danger, and they may need a 24-hour treatment setting. Now, the difficulty is in getting more days in a 24-hour residential setting is if you have people who have problems in any of those 6 dimensions, but it's not needing 24-hour care. And if you're able to go out on a pass, you don't need 24-hour care. You may need a 24-hour living support environment, but you may not need 24 residential treatment. So that's where we run into problems sometimes in getting longer lengths of stay in residential, because they don't really need 24-hour treatment. They need 24-hour living support with some intensity of clinical services. Incidentally, when people think about ASAM level 3.3, and we talked about this briefly yesterday, when you're talking about some of these residential levels, a reminder that 3.3 is more for people with traumatic brain injury or cognitive disorders, whereas 3.5 would be more traditional residential level. But again, for people who, if they're not there, would be in some danger if they're not getting 24-hour treatment.
Well, thank you. That was a good question and great information. So let's turn to some questions that John Zoller, who has asked. First, the vast majority of drug courts require all of their clients to participate in either an outpatient services program or an intensive outpatient services program in a group format. Can you provide some suggestions to programs for improving clinical services where this group format for treatment may be their only treatment option because of budget constraints?
Group format is fine as long as we use the groups in a way that can allow people to do an individualized treatment plan. So, for example, and I mentioned this yesterday, I think, if anybody is running groups, one of the things you can test out to see whether you have people participating in individualized treatment to say, before we start the group today, let's go around and each of you tell me in 30 seconds or less, what do you want to get out of the group today to advance your treatment plan? If you get a deer in the headlights look, or somebody saying, what treatment plan, or what do you want me to say, or I just have to be here, or I just want to gain insight, or something generic, that tells you individualized treatment's not going on, that they're just going through the groups to be part of the program. What you would hope you would hear from somebody who's getting real treatment is to say, I don't even have an anger problem, but I want to get a probation, and I have to be looking at anger, but I don't think I have an anger problem. So in my treatment plan, in group today, I'm going to ask for somebody to role play an angry situation. Other people would get into a fist fight, but because I have good anger management skills, I'm going to demonstrate to the group how to handle that angry situation in a nonviolent, assertive way. And you're going to note that down and let my PO know that I have good anger management skills. I don't even have a parenting problem, but I want to get my kids back, and I have to be in this group, or I agreed to be in this group. So in my treatment plan, I'm going to ask for a difficult parenting situation, the kids having a tantrum, pulling everything off the shelves in a supermarket. Other parents would slap their kids, but not me. I have good parenting skills. I'm going to demonstrate to the group how to handle that situation without being violent, but being firm, setting consistent limits. You're going to note that down and let my child protective services worker know that I have good parenting skills. I don't even have a drug problem, but I want to get out of drug court, and I don't see anything wrong with my friends. So I'm going to, in my treatment plan, describe in group today who my friends are, what they're like, what they do, and get feedback from the group about whether hanging out with these friends will increase or decrease my chance of getting arrested again. In other words, the treatment can be individualized in a group format, and the power of that is that you have people who are at different stages of change. You can say, that's exactly what I said, but let me tell you, buddy, this is what had to happen. I had to get arrested 5 more times before I realized to take this seriously. Or somebody else who is further along in recovery can say, this is how I moved from the point you're at. I'm with you. That's how I felt. This is how I can, you can learn from my mistakes, or you can make your own mistakes. But so that's the power of group. But again, if people are in groups just getting checked off for attendance, that's not doing treatment and change. And so groups can be powerful as long as treatment providers are really doing individualized treatment, and court teams should expect to hear that kind of treatment plan. Otherwise, you may just have somebody drifting through a program.
Thank you. So let me go to the next question from John Zoller. The federal government has strongly supported the adoption of high-risk and high-needs defendants as the primary target for drug courts. What level of care is typically called for in treating someone with a substance abuse disorder in the high severe range, also considering that other issues usually accompany this drug court participant? I think we talked a little bit about that yesterday.
Yeah, I think we have to make the distinction between high risk, high need from a criminal recidivism approach versus high risk, high need from a clinical approach. What I would say that is, if somebody has high risk, high need from just legal sort of recidivism approach, that might identify what population we want to invest most resources in, because we want to put the most intensive resources in the people who are going to most likely to reoffend, and that's fine. But what I also would say is that we need to have a variety of services for anybody who has addiction, not just high risk and high need, if we think their addiction illness is accounting for their offending behavior and the public safety. So the issue is understanding whether we're talking about high risk, high need in terms of legal recidivism or high risk or high need in terms of clinical sense. Either way, that person needs to get an individualized treatment plan, and we can sort of ration, as it were, resources to meet the highest needs. I would make an argument for also broadening out services to less intense levels and interventions for people who may not be high risk and high need, but still are likely to reoffend because of their addiction illness. And this goes all the way to impaired driving as well, where we need to move beyond compliance in classes to really assessing, is this person likely to reoffend, and are they needing treatment for their addiction then, even if they may not meet traditional high-risk, high-need sort of parameters on different instruments.
Thank you. And as I mentioned yesterday, one of the things that we're trying to promote is to have multiple tracks in the drug court so that it can be the services can be individualized to the needs of each individual and also changed as reassessments may dictate. So technical assistance is available. Just follow up with us on that. Okay, so here's a question from Lisa Keating. The use of methadone is controversial within our court program. How do you feel about the use of methadone in comparison to other medication-assisted medications?
Now, I understand there are often lots of different attitudes about medication-assisted treatment, or as I would really call it, medication in addiction treatment. And those attitudes and concerns are not just from court personnel, but also treatment providers who have, some treatment providers have very mixed feelings about using a medication which itself can be addictive. On the other hand, we started yesterday's webinar with a reminder that addiction as a brain disease has real functional changes and real problems for somebody who has addiction in terms of the brain reward system and dopamine and other neurotransmitters. And so when we're talking about medication in addiction treatment, we're really addressing the need for some people in addiction treatment to need medication, just like some people with hypertension need medication, some people with asthma need medication, some people with schizophrenia and depression need medication. So methadone often is controversial in court teams for a variety of reasons. One is that they may see people in a methadone maintenance program where the program is not very good quality, is focused more on just dosing people with the medication and not doing enough with some of the psychosocial-spiritual aspects of recovery, and where any counseling is done to sort of meet federal guidelines for a person to show up, but really isn't focused on a recovery treatment plan. And then the court sees, rightly so, this person is just getting methadone, but they're not really changing. There's no evidence that they have given up sometimes other drugs. There's no evidence that they are growing physically, mentally, spiritually, socially to advance the public safety. They are basically just somebody who's getting methadone but hasn't really changed. I can understand courts being reticent to see methadone as being a legitimate treatment. But that says more about poor treatment than it does say about the methadone itself, because there are other people who are on methadone who wouldn't be able to function and grow as well as they have because of damage in their brain reward system that needs the methadone to help them to develop. This is a much bigger discussion, but the quick answer is that any medication in addiction treatment, whether it be methadone or buprenorphine or medication for people with alcohol use disorder like Antabuse or naltrexone for anti-craving medications, or acamprosate, which is Camprel. In other words, there's medications for alcohol, there's medications for nicotine, one of the deadliest addictions, nicotine addiction, and there's medication for opioid use disorder. I would encourage court teams to understand that medication, if used in conjunction with good recovery-oriented biopsychosocial spiritual treatment, can go a long way to improving outcomes, that we shouldn't cut off any opportunity to get the outcomes we want. Having said that, if you see somebody on medication who is not getting good psychosocial spiritual treatment along with it, yes, we should call the question, and it's not on the question isn't then on the medication, it's on the poor treatment of people, the poor quality of treatment of the people who are getting the medication, where both the client and the treatment provider be more focused on the medication than they are on recovery and change.
Thank you. Okay, turning now back to the kind of level of care and treatment dosage. This is from Craig Ogilvie. Is there still a minimum amount of hours of treatment required to be labeled as intensive outpatient treatment as defined by ASAM 2.0? Are we not held to a minimum total amount of treatment hours in our program, 200 hours or so, to meet criteria?
So in the ASAM criteria, there are hours defined by the outpatient levels, and that's more to do with making sure we have a common language, that if somebody says we have an intensive outpatient program, that when they say we are an intensive outpatient program, we know what they mean. And in the ASAM criteria, that means that you are getting 9 or more hours of clinical service. Now, 9 or more hours doesn't mean going to an AA meeting and counting that as 2 hours or an hour, because that wouldn't be clinical work. But individual therapy, group therapy, family therapy, having a psychiatric evaluation, clinical treatment is defined in the 9 hours or more to define intensive outpatient. And then as we talked, there's different hours for different levels. For partial hospital, 20 hours of service a week, and so forth. So those hours define the level of care just to define a certain intensity of service. It doesn't tell you how many hours a person needs for their treatment plan. Now, when you see numbers like 200 hours and so forth, this is based on research that might say for a person to actually improve in terms of criminal recidivism, they're going to need a certain base dose of, say, cognitive behavior therapy. That you can't expect if somebody gets 5 hours of CBT that you can expect a good outcome in terms of clinical recidivism. Or in the clinical area, people have talked about people need a certain dose of at least 90 days of treatment to get any chance of decreasing their relapse potential. But that 90 days doesn't have to be all in residential. It could be 90 days in a continuum of care. It's basically saying, like what you do with antibiotics, that, doc, can I get over my infection if I just take antibiotics for a day? No, you need a certain minimum dose. And if you feel better after 5 days, I want you to take the whole dose for the 10 days because you won't get sustainable improvement. And that's the same sort of thing in behavioral health and addiction treatment. There needs to be a base amount of treatment, but that shouldn't be both the ceiling and the floor, meaning, so 200 hours has been shown to perhaps impact legal recidivism. If they get that amount, therefore we will mandate everybody to get 200 hours or something. It has to be individualized. We're really just talking about statistical research things that say you have to get a certain amount of dose to get sustainable change. But then don't make that the new normal about what everybody should get. It's just saying make sure they get a big enough dose and then track their outcome based on individualized assessment and progress.
Thank you. So I should have asked included this question when you were talking about MAT. This is from Jeff Kushner. How do we best determine who needs medication and who does not?
Well, there's criteria for who needs medication in terms of medication for withdrawal. There are very specific criteria in the ASAM criteria who needs treatment for withdrawal. And I think we all understand that sort of detox withdrawal management. But when we're talking about who needs it in terms of Dimension 5, the relapse dimension, does this person need methadone? Do they need to be on a methadone program, or could they do abstinence? Those are the sorts of things that really a complex discussion of looking at various needs. Say, for example, you had somebody in the 6 dimensions who had tremendous difficulty with cravings to use on Dimension 5, and what they are having trouble with is no good skills to be able to suddenly stop their heroin use or their OxyContin use. And they need some time to be able to stabilize and not to go into withdrawal from their opioid use, which will only spark them to start trying to get more drugs. Then that might be a person who you would say, let's have them be on some methadone to stabilize things, to give them enough of a breathing chance to get learning some other psychosocial attempts. On the other hand, you might have a person who's very ready to change. They know they have a heroin problem. They want to stop. They've even been in recovery before, so they have some good Dimension 5 relapse prevention skills. They've been to NA before on Dimension 6, so they have a good recovery support system. They can call up their old NA sponsor again. They can get back to their home group. They have a supportive family, and they say, I've tried methadone before, I don't want to do it, or I haven't tried it before, but I really want not to be on any medication. That person you would not give medication to. So it isn't a simple formula. It's the way that we decide on medication with any other illness. What's the severity? What are the complex issues going on? And the decision about medication is often a mixture of all of the 6 dimensions for that particular person. And it isn't like all people at a certain age or a certain diagnosis get it and these other people don't. Same with alcohol. Who do I give anti-abuse to? Who don't I? Those are clinical decisions which shouldn't be made by a judge or a court team, but if you have a good treatment provider, they should be able to describe how they decide on medication and explain that to both the client and to the court team. And what I'm saying that the decision to use medication is not unidimensional. It's often based on a combination of factors. And this is where, when we encourage you to have the session that we're planning for March 29, we would love to have at least 2 cases where people bring in real situations and say, is this a person we should give medication to? That's why we want to apply these principles to real cases. So that would be another place that we can help understand how you make these decisions. But they are clinical decisions, not policy decisions.
Thank you, and that's an extremely important point. So let's kind of shift gears and look at not just assessing the individual, but assessing the effectiveness of the treatment. This comes from Hartwell Dowling. How can a treatment agency provide outcome data regarding the efficacy of its services in a longitudinal way? Typically, agencies do not have the resources to do this or do not feel such data is really attainable.
So when we're talking about outcome data, you have to understand the different purposes of it. So there's outcome data which can be longitudinal, like are the people in your program, what's their legal recidivism rate? How many of the people stay abstinent, or if they don't stay abstinent, at least stay out of trouble in terms of public safety and legal recidivism? How is this person doing in terms of their physical health and their mental health? So for those of you who are using the Addiction Severity Index, that can really look at psychiatric severity, physical health, family, social relationships, legal recidivism, drug use and alcohol and so forth. forth. You can look at those longitudinal outcomes and look at what are the stakeholders really looking at. So a criminal justice setting is going to be wanting to look at legal recidivism and public safety. An employer would be interested in looking at absenteeism, presenteeism, which is the person's at work but not really present and very productive, want to look at productivity rates, want to look at workers' compensation, wanting to look at, the efficiency of their work. A child protective agency will be wanting to look at parenting skills and safety in terms of further abuse situations. So those are the longitudinal outcomes. And those can best be collected by working hand in hand, a treatment provider with the important stakeholder to look at the population of those treated and to be tracking the kinds of outcomes that are important to the stakeholder. On a clinical sense, we need to move, and we're not there yet, to looking at outcomes more in real time. And there's work being done with that in terms of feedback-informed treatment. If you look at the work of Scott D. Miller, or if you Google outcome rating scale and session rating scale, these are technologies. They're not even all that technological, but these are quick ways to look at, is a person getting better individually, interpersonally, socially, and overall? That's in the outcome rating scale. And then the session rating scale is tracking in real time the quality of the therapeutic alliance. Are we working on goals that are important to you? Do we have a working relationship that fits for you? Do you feel that you can be honest with your goals, and so forth? So that's tracking in real time the quality of the alliance. Do we have somebody engaged in the self-change process? There's other work that's been done on outcome measurement-based treatment, this is often called, the work of John Kelly at Harvard. So there are some attainable outcome mechanisms to give feedback in real time, to be tracking the progress without thinking outcome studies means big research studies, tracking people down 6 months, 12 months, and that kind of thing. But that's a whole nother topic about what outcomes are meaningful and how can we practically do those in the real world.
I think those are really important points because we've talked about criteria for the team and the judge and the other members to look at the degree to which the treatment provider is complying with evidence-based practices. But I think this gives us another level of assessment, getting some participant feedback as well as looking at those indicators that you suggested that are and I'm assuming dropout rates also would be important.
That's right. That's some important data, yeah.
And this is important that we will work with programs. If you're interested in any follow-up on this, we would be happy to help you. So I think we have time for one more question. Again, and this came from John Zoller. What repeated measures do you recommend using to document improvement of a drug court client as he or she moves through a treatment program? I'm unaware of any well, this is really geared to phases. Suggestions on moving beyond the current way of examining this issue. So if we're going to have phases, how would you, Dr. Mee-Lee, structure the phases to have them geared to the individual situation of the clients in them?
Yes, and we are going to, a lot of these issues we are going to keep addressing in subsequent webinars. So don't feel if your direct answer question wasn't answered, that it's never going to be answered. But if you're going to have phases, and if we're going to look at repeated measures, I wouldn't be so focused on a repeated measure instrument. I would be focused more on, again, looking at what level of function does a person have in each of the 6 dimensions and how are they improving in their treatment plan. So phases should be function-based, not compliance-based. In other words, if you have phases that are just based on, okay, they're showing negative drug screens and they're attending all prescribed meetings and they're going to 3 AA meetings, and once they reach all of those things, they can move to the next phase. There are many clients who can bite their lip and bite their tongue and follow through with doing things that look fine, but that doesn't equate to improved change and sustainable functional changes that increase public safety and decrease legal recidivism. So I would be focusing on phases, if you're going to use phases, that have to do with what are the demonstrated changes in their progress that helps us to know that they are improving in terms of public safety. Now, that's going to be different for different people. If you have a person who comes in on day one and on dimension 4, they don't think they even have a problem, and on dimension 6, they don't see anything wrong with hanging out with those friends, you're going to be wanting to not move them to the next phase unless you see that they are beginning to change in terms of their belief that they have an addiction problem. Not just saying, okay, I have an addiction problem, but are they demonstrating when they go to an AA meeting that they can identify with somebody's story? Are they able to start talking about from their heart about, I see now how what I'm doing here has been causing a problem. And on dimension 6, I'm not ready to give up all my friends, but I can see how these friends I have to give up. I mean, these are things that have to be tracked in terms of what were the problems in each person's individual assessment. If somebody on dimension 2, the physical health dimension, has a chronic pain problem, are they improving to look at other ways to deal with that with physical therapy rather than just always wanting more OxyContin? If this is a person on dimension 3 has trauma issues, are they getting into grips with that so that they don't just have outbursts if they've got PTSD? Are we seeing an improvement in their ability to handle impulse control? That's why it's very important to have the phases be based on the function for this person and how they're changing in their treatment plan, not on their ability to jump through certain hoops, which doesn't necessarily translate into real functional change. We've seen people, quotes, graduate, and then they're rearrested within a short time, or they haven't actually changed because they were just going through the motions, looking like they were achieving the goals of each phase when those goals are really compliance goals about did they attend group, show negative drug screens, go to so many meetings. Those aren't function-oriented.
Well, thank you, Dr. Mee-Lee, and thank you, everyone, for joining in this follow-up session. As we mentioned, the next session will be on March 14th, but we would like to receive your, any challenging cases that you can send in as soon as possible because we'd like to incorporate them into our sessions as well as have a good array of cases that we can base our March 29th kind of clinical challenging case session on and send them out in advance so that people can have a chance to look at them. So thank you again for joining with us. Please send us an email just indicating that you attended the session and you're requesting a certificate of attendance, and we will be glad to send that to you. We will also send out the PowerPoints and the recording and the link to where you can find it, and we will follow up with you on the question about the CEUs shortly. Thank you, everyone, and we look forward to talking with you on the 14th, if not before.
Thank you.
Thank you.